Hello, this is Kim Jong-il. Today's lecture will be on treatment using headgear. First, we will look at cervical headgear. We can see a lot of children wearing headgears like this in foreign cartoons. The term cervical headgear is used for types that pull from the neck area, and the term high full headgear is used for types that pull from the top of the head. The headgear consists of an inner bow, an outer bow, and a neck strap. The headgear is used to treat Class II malocclusion. To be more specific, for cases of Class II malocclusion where the maxilla or maxillary molars are positioned anteriorly, the headgear can be used to suppress the growth of the maxilla and move the maxillary molars posteriorly. There are various patterns of tooth movement depending on the different types of headgear. The high-pull headgear is pulled from the top of the head. The force directs backwards and upwards. Therefore, the maxillary first molar is intruded and distalized. Due to the intrusion of the maxillary first molar, the UOP is steepened. On the other hand, the cervical pull headgear is pulled from the neck. The force directs backwards and downwards. The maxillary first molar is extruded and distalized. Because of the extrusion of the maxillary first molar, the UOP is flattened. The headgear is classified into 3 types depending on the direction of force. Many people think that the high-pull headgear should be used for high-angle Class II cases, and that the cervical pull headgear for low-angle Class II cases. High-angle Class II has a retrognathic mandible. How are high and low angles diagnosed differentially? Many judge by the mandibular plane angle. Others diagnose with ODI. However, in mio-orthodontics, we diagnose with the combination factor. If the combination factor is greater than 155, we diagnose low-angle Class II, and if it is less than 150, it is high-angle Class II. Should we use the high-pull headgear for high-angle Class II? I personally do not use the high-pull headgear for the following reasons. Firstly, the maxillary molars would intrude. Intrusion of the maxillary molars steepens the UOP and may cause over-eruption in the mandibular molars. Secondly, posterior discrepancy may be caused. Thirdly, the skeletal volume itself does not change. Fourthly, although we might use high-pull headgear for non-extraction treatment, it is not necessary when we need to extract the premolar. We need to think of this carefully. Firstly, the maxillary molar intrude. Since the direction of the force is backward and upward, the maxillary molars are intruded and UOP is steepened. The mandibular molars extrude. I consider the extrusion of the mandibular molars as an etiological factor of Class II malocclusion. If the mandibular molars are extruded, it is very likely that the mandible will not be able to protrude forward. Secondly, if the maxillary first molar is moved to the backward and upward, what would happen to the maxillary second and third molar? Because backward and upward force is applied, the maxillary second and third molar will move backward and upward accordingly. This can induce posterior discrepancy. Thirdly, the skeletal volume itself does not change. There is the palatal plane, the AB plane, and the mandibular plane. If we look at the skeleton, the ODI is 70, APDI 75, and CF 145. Can these values change to 75, 80, 155 even with the intrusion of the maxillary first molar? The answer is no. The combination factor is sufficient in the case of ODI 80, APDI 75, and CF 155. This would be a case of Class 2 low angle. The ODI may change as the mandible protrudes forward and the maxilla moves slightly backward. The values may change to ODI 75, APDI 80, CF 155, resulting in a Class 1 low angle. Because Class 1 low angle has an acceptable profile, non-extraction treatment is possible. ODI is 75, APDI is 73, and CF is 148. This is a case of Class 2 high angle. How would the ODI change if the mandible is pulled forward? Since the CF remains unchanged and the APDI must be 80, the ODI decreases. Because the values change to ODI 68, APDI 80, and CF 148, it becomes a Class 1 high angle. Class 1 high angle has a small skeletal volume, so we probably have to extract a tooth somewhere. Although we can use cervical headgear for cases of Class 2 low angle, we don't necessarily need to use headgear for cases of Class 2 high angle because we probably need to extract anyway. Fourthly, we can move the molar backward like this. If the facies are aesthetic enough after we move the molar backward, we can perform non-extraction treatment. However, we still may need to extract a premolar somewhere if there are signs of lip protrusion. A is a case of insufficient anterior growth of the maxilla, or when the maxilla is in its normal position. B is a case of sufficient anterior growth of the maxilla, or when the maxilla is located anteriorly. The distance from the PNS to the maxillary first molar is large in case B and small in case A. If we push the maxillary first molar upward and backward, case B would be fine, but case A would experience posterior discrepancy, increasing the chances of having to quickly extract the maxillary second or third molar. How should we differentially diagnose whether or not to move the molar backward? Through evaluation of the posterior discrepancy. The posterior discrepancy differs depending on whether it is high or low angle. In MIOW orthodontics, as long as the face is not too unaesthetic for cases of Class 2 high angle, we can extract the maxillary second molar and push the maxillary dentition backward by using the space created instead of using headgear. This is why high-pull headgear is unnecessary for cases of Class 2 high angle. When pushing the maxillary first molar posteriorly, the center of resistance of the maxillary first molar is the furcation area. It is best to apply force to the furcation area as shown in case B. This would result in a translation movement like this. If force is applied to the crown side, there may be crown distal tipping. On the other hand, if force is applied on the apical rather than the furcation, there may be root distal tipping. It can either be a cervical pull or a high pull depending on the position of the neck strap, and the force may be applied like A, B, or C. What would happen if the outer bow is aligned with level A? The maxillary first molar would be extruded and experience distal crown tipping. What if the outer bow is positioned like number B? There would be bodily distal movement at the maxillary first molar. How would it move if force is applied as shown in case C? There would be distal root tipping and the maxillary dentition is moved backward. Which of A, B, and C would be better for Class 2 malocclusion? Movement as shown in case C is preferable. The position of the inner bow of the headgear is determined by the maxillary arch. The inner bow should be adjusted so that the lips are comfortable when it is placed on the double buccal tube of the maxillary first molar. By adjusting the length and direction of the outer bow after the inner bow is fixed, we can achieve the desired occlusal force. If the outer bow is long, there would be counterclockwise movement, and if the outer bow is positioned downward, there would be clockwise movement. The best treatment for Class 2 is inducing counterclockwise movement. Therefore, it is important that the outer bow is positioned upward. The position of the inner bow is determined by the patient's maxillary dental arch and lips. The outer bow should move upward. Because I mainly use the cervical pull headgear, the maxillary first molar is extruded like this. As shown in the picture below, the outer bow must be positioned upward to induce root distal tipping. Although it would be best to understand all 9 cases, please remember that because we only use cervical pull headgear for cases of Class 2 low angle, we must position the outer bow upward. Root distal tipping and crown mesial tipping happens with the extrusion of the maxillary first molar. The maxillary first molars move backward in general. Let's review. For cases of Class 2, should we move the maxillary molar backward like example A or B? If we apply force, it could easily move like example B. However, it is difficult to move dental roots. Therefore, it is important to move like example A. The maxillary dentition should move backward with root distal tipping and crown mesial tipping. To do this, we must use a cervical strap and outer bow must be long. The long outer bow is to induce counterclockwise movement, and it should be located above the first molar as such. To review this again, the inner bow is parallel to the occlusal plane. Make the outer bow long and place it above the first molar. If the outer bow is long and located above, it would be located in the furcation area, the center of resistance of the maxillary first molar. If the outer bow is even longer and positioned further upward, how would the teeth move? There would be root distal tipping and crown mesial tipping, moving the maxillary dentition backward. What we need to make sure is that the outer bow must not be positioned down like this. Since the neck strap pulls the outer bow backwards and downwards, attaching the neck strap lowers the outer bow. Considering that the outer bow should be positioned upward even after attaching the neck strap, it should be positioned more upward than we thought. The patient must wear the headgear himself. It is not easy to wear the headgear when the maxillary first molar is in mesial in rotation. In this case, first, the buccal surface of the maxillary first molar must be made parallel. Only after that should we let the patient wear the headgear. Headgear should be worn after derotating the mesial in rotated maxillary first molars. For derotation of the maxillary first molar, we first use a 2-4 appliances on the maxilla. Brackets are attached to tooth number 1, number 2, number 6, and or first primary molar for cases of long span and open coil springs are used. Headgears have orthopedic effects. In other words, the entire maxilla may move posteriorly. If we use the anterior bite plate here, the mandible can be positioned forward. This is why I use headgear and ABP together. Their combined use maximizes each of their effects. Let's review this again. We derotate the maxillary first molar with a 2-4 appliances on the maxilla. Attach the device to tooth number 1, or 2, NUR D, and NEAR 6, and use the open coil spring on 4 locations. After paralleling the buccal surfaces of the maxillary first molars, we use the cervical headgear and anterior bite plate together. We use a double buccal tube on the maxillary first molar. There is a round tube with a large diameter in the double buccal tube. Should the round tube where the inner bow is located be positioned on gingiva or occlusal area? When the round tube is located gingivally, we can move the maxillary first molar more effectively since it is closer to the center of resistance. But this is not good for oral hygiene. This is why I place the double buccal tube occlusally. There are several types of inner bows. In order to form a stop, we can bend the inner bow into a U shape in front of the tube. The U shape can also be placed gingivally or occlusally. Recently, the U shape is often positioned occlusally like this. The second method to form a stop is by welding with a spacer. The third method is to bend the inner bow inward in front of the tube in the opposite direction of the molar offset. The important thing here is that when the inner bow is placed in the round tube of the maxillary first molar, there needs to be 3 to 5 millimeters of space from the labial surface of the maxillary incisors and the junction. There needs to be enough space for the maxillary first molar and the maxilla to move posteriorly. Let's review this again. The outer bow should be long and located upward. I recommend raising the inner bow to the same level as the posterior alar cartilage. The force applied should be around 400 to 500 grams, and the patient should be informed to wear the appliance for 12 to 14 hours a day. It does not necessarily need to be worn during school hours, but it should be worn from the moment the patient returns from school, even during sleep. The anterior bite plate should be worn together. Let's look at the clinical control process. In the first month, only the anterior bite plate is worn. Inform the patient to wear it at all times except when eating and brushing teeth, and that it is important to keep the mouth closed. Headgear delivery is performed in the second month. Inform the patient to wear it 14 hours or longer a day, and adjust the headgear. Normally, the headgear is only worn after school and at night for 6 to 9 months. This is a Class II low-angle case of ODI 80, APDI 75, CF 155. The APDI must be increased to 80. Because the ODI value is big enough, it will still be 75 even if the APDI becomes 80. Therefore, it can be changed to a Class I low angle. In such cases Class II low angle, we can use cervical headgear. This is a case of Class II high angle. The ODI value of 75 may make you think this is normal. But the combination factor is small. We should never use headgear in cases such as this. For the APDI 73 to become 80, we need to take away 7 from the ODI. This would result in ODI 68, APDI 80, CF 148. This is still a Class I high angle. It is very likely that the lips would still be protruded. In this case, we would have to perform extraction. So I suggest that you use cervical headgear only for growing children. The advantage of using a headgear is that it can suppress the growth of the maxilla. Overjet is improved, arch is expanded, and the molars can move backward. The disadvantages are that patient cooperation is crucial and that it can't be used for adult patients. Extraoral appliances have clear disadvantages. Let's review the differential diagnosis of a Class II skeleton. Closely observe the edge-to-edge bite profile. It may display slight protrusion. This patient is a growing child. What does it mean to be protruding in this case? It means the maxilla is protruding. The mandible may be located normally or backward. If the maxilla is protruding, it should be positioned backward. On children who are still growing and have a large combination factor, we may use headgear and ABP. This is a 10-year-old male patient. The ODI is 84, APDI 72, CF 156. In such cases of excessive overjet, we can use headgear. This is an 8-year-old female patient. The ODI is 76, APDI 72, and CF is 148. Many would diagnose this patient as a case of low angle due to her ODI of 76, which is large, and attempt to treat by using headgear. If we use headgear on patients with a small CF like her, the mandible is likely to position further posteriorly. Therefore, in this case, orthodontic treatment through extraction would be a better option than using headgear. How would we treat an adult patient with a skeleton like this? We must perform orthodontic treatment with extraction. Non-extraction treatment would be difficult because an adult patient would already display lip protrusion from edge to edge bite. Thank you for watching.